Okay, everybody, we're going to go ahead and get started. It's my understanding that this is the last day of the course. Uh, so, except the exam, importantly. So my name is Ms. Shayla Rubin. I'm an endocrinologist here in the Metabolic Bone Disease Unit, and I really love coming to give this lecture every year because 20 years ago I was sitting in your seat taking this same course, and I don't really remember much about the bones, and that might be just because I forgot a lot, but I think it's also because 20 years ago a lot of what I'm going to tell you today probably was not even known. I don't have any disclosures, so today I want to give everyone an overview of the epidemiology and diagnosis of osteoporosis, and then more towards the end of the talk, an overview of other metabolic bone diseases. So osteoporosis literally means bone with too many holes in it in Greek. And what happens in the disease is that the holes in the bone become wider, so instead of having bones in them, they become filled up with bone marrow or with fat, and that renders the bone more weak and more likely to fracture. And it's really a big deal. In this country, there are 2 million fractures that are occurring every year. It's expensive, and it affects 10 million Americans, 80% of whom are women. So it's a common problem. And if you expand to osteopenia, the problem is even larger, involving 34 million people, and you could see that it stacks up pretty well next to the other big gun diseases that we think about as being really important, like hypertension and high cholesterol. Perhaps even more impressive is the statistic that if you are talking to a 50-year-old Caucasian woman, she has a 50% chance of having an osteoporotic fracture sometime over the rest of her life, which really is much bigger than her risk of having breast cancer, something that women tend to worry a lot more about. In a similar vein, a 50-year-old man has a 20% chance of having an osteoporotic fracture at some point in the rest of his life, which again is comparable or even more than the risk of having prostate cancer. So the main areas that we worry about in osteoporosis are fractures of the spine, the hip, and the wrist. You could really have an osteoporotic fracture anywhere in the body, but these are the ones that are the most common and the ones that have the most serious consequences. Now, it's important to remember that until someone has a fracture, it's a silent disease, and they won't have any symptoms of it. Once a patient has a fracture of the hip or a wrist, they are going to have pain from it, but fractures of the spine aren't always associated with pain, and in fact 2/3 of spine fractures are silent, and the patient never even knows she has it unless it's picked up on an x-ray. So a hip fracture is the most devastating and dreaded consequence of osteoporosis. It happens after a patient falls, usually, typically falling to the side. The patient needs to be treated in the hospital and to undergo surgery. And 20% of people who have a hip fracture are not going to survive the year. In addition to that, even if they survive, they're going to be left with multiple impairments and compromises in their daily function. And perhaps most alarming, once someone has had a hip fracture, they have a 2.5-fold increased risk of having another hip fracture. So this is really something that prevention is the key. We just don't want it to happen in the first place. Now, having a spine fracture is not as catastrophic as having a hip fracture, but it also carries its own morbidity. Patients typically develop back pain, loss of height. The spine develops a kyphoscoliosis abnormality. This can lead to kinds of an outpouching of the abdomen, so patients develop early satiety and don't get the same nutritional intake that they should. If they have thoracic compression fractures, they could have less room for the vital capacity of their lungs, and this can lead to decreased pulmonary function. Patients have trouble being able to lie flat and sleep well, and perhaps the most poignant thing of all, if you take care of these patients, is to see the loss of self-esteem that develops with having this type of disfigurement, and oftentimes patients can develop depression as well. Now, even though we think of osteoporosis as a disease mainly of women, it also can involve men, and about 1/4 of the cases of osteopenia and osteoporosis involve men. And if you think about it, there's probably even more cases than that because we're just not looking for it as diligently in men. So when it comes to this disease, you could actually say that men are really the forgotten gender, and there's probably even more of it that's present than we're aware of. So I'm just going to recap a little bit what Dr. Dempster already told you about the pathophysiology of osteoporosis. And he probably told you how incredible bone is. And as a bonehead, I believe this myself, that over millions of years of evolution, bone has evolved to have many amazing properties. It's as strong as iron, but at the same time, it's as light as wood. It's able to adapt itself to functional needs. So, for example, a tennis player will have much stronger bone in her serving arm than in her non-serving arm. So the bone is able to dynamically respond to the demands that are put upon it. And if it breaks, the bone is able, in a very dynamic and alive way, to be able to repair itself. And as you heard from Dr. Dempster, this is because of the cells that live in the bone. We have the osteoclast cells, or the bone chewers, which are able to dig out a resorption pit when there's old or damaged bone. And that's followed by osteoblasts, the bone building cells, which come in and lay down the unmineralized osteoid, or the organic or protein matrix of the bone, which subsequently over time will gradually become mineralized. Oops, sorry. Okay, so the ratios of these activities of bone formation and bone resorption depend on what stage in your life you're at. So obviously a young person is going to have greater bone formation than resorption because they're growing their bones, and this continues until we reach about peak bone mass, which is probably about how you guys are at in your lives. Sometime between the age of 20 and 30, we have the most bone we're ever going to have for the rest of our life. And this is a time when bone formation really equals bone resorption. And then after age 30, your amount of bone mass starts to slowly decline. And then when women hit the age of 50, there's a very rapid decline in bone mass. And this is because with menopause and the decrease in estrogen, you lose the normal inhibitory effects of estrogen on osteoclasts. So there's a very accelerated state of bone resorption. And for the first 5 years of menopause, women can lose about 5% of bone density a year. So it's a very vulnerable time with rapid bone loss. And then things kind of slow down and plateau so that there's still kind of a constant state where bone resorption trumps bone formation, but it's not to the same accelerated degree as during the time of menopause. So it's very important during this time of bone acquisition to reach your peak bone mass, because it's kind of like you're putting money in the bank, because after age 30, everybody's going to lose bone no matter what. So during these years of growing your skeleton, you want to really be able to maximize the nutritional input of calcium and vitamin D and minimize any conditions which could prevent the optimal acquisition of peak bone mass. So somebody who has low peak bone mass, and this could be due to genetic factors, which you can't really do much about, but also other factors such as decreased nutrition or maybe even a disease or a medication that hurts your bone, is going to be starting out with less bone because they didn't acquire as much as they should have when they're younger. And then if coupled with that, someone loses bone as they get older, and this can happen just because of the bone loss we were saying happens in menopause or because of medications or diseases, they can have increased bone loss. So having either low peak bone mass and or increased bone loss with aging could lead to a decrease in bone quantity and quality, and then if a traumatic event happens, the outcome we want to avoid, namely a fracture, occurs. So it used to be thought that osteoporosis meant that you just didn't have enough bone, that there was too little bone, so it was simply an issue of quantity. But we now know that it's an issue of poor bone quality as well, and that people who have osteoporosis have microarchitectural deterioration of their bone that makes it more fragile and more vulnerable to fracture. You can see in this picture here with these spicules how there's been a dropout so that there's going to be a separation. So in the microscopic struts of bone, there are these tiny changes that are also going to adversely affect the quality of the bone and not just the quantity of the bone. So some overall risk factors that any doctor really could think about when seeing a patient in the clinic include the patient's age, has she recently undergone menopause, lifestyle factors, medications, diseases, has she had a fracture, did her parents ever have a hip fracture? So I'm going to go in detail through each of these, but these are some things that a doctor could easily engage a patient in just to get a sense of her risk factors. So lifestyle risk factors that one would want to be alert for include a low intake of calcium and vitamin D. Is the patient at increased risk of falling? Does the patient, for example, have a neurologic abnormality, vision issues, poor gait that could predispose her to fall? Is she immobilized? Even if one of us were laid up in bed for like 3 days, we would start to already lose bone just from lack of muscle stress on the periosteum. If someone's excessively thin, it's thought that a weight of 127 pounds is kind of a cut point. Anything less than that puts them at risk. If someone has a lot of caffeine, that could promote calcium loss in the urine. If someone drinks or smokes, that can have a harmful effect on osteoblasts. So any of these could harm the bone. And I just want to emphasize the points of falling, that anyone who has a vulnerability that's going to predispose them to fall is going to be at increased risk for fracture. And this is something that patients who are predisposed, if they're even on sedative medications, if they have rugs bunched up in their home, these are things that can easily be altered to prevent patients from being more likely to fall. So in terms of genetic risk factors, there are many diseases, but really what I want to emphasize, the most important thing is, did your parent ever break a hip? Because that's been shown epidemiologically to be an important risk factor for fracture. And it could be whether your mother broke a hip or whether your father broke a hip. But if you do have this risk factor, it will significantly increase your likelihood of having osteoporosis. Hypogonadal risk factors basically include anything that means a low estrogen state. So if a woman has undergone early menopause or had premature ovarian failure, if she has the athlete's triad of having amenorrhea and excessive exercise, anything that's going to lead to low estrogen levels is going to predispose someone to having osteoporosis. And we also know, in fact, that low estrogen levels in men are also a risk factor for osteoporosis. And then there's a laundry list of many diseases that are associated with osteoporosis. In the endocrine category, if someone has primary hyperparathyroidism, that can hurt the bones. So can excessive thyroid levels. That can eat away at the bone, in particular the cortical bone that's in the arms and legs. Gastrointestinal disorders, highlighting here celiac disease. I've had a number of patients in my clinic who didn't have any symptoms of celiac disease but presented with decreased bone density, and celiac disease is one of the things we screen for, because a patient who's having a reaction to gluten in their intestine is not going to be able to properly absorb calcium and vitamin D in their intestine, and that can manifest itself as bone loss. Hematologic disorders like multiple myeloma can be associated with osteoporosis, and rheumatologic disorders, most importantly rheumatoid arthritis, can also be associated with osteoporosis. So when a patient comes to see me in the clinic and she has osteopenia or osteoporosis, kind of the first thing I'm going to do is think about, is there another issue going on here? Does she have a separate disease, or is she on a medication that could be hurting her bones? So this is something that you want to figure out before just prescribing a medication to the patient, because if there's an underlying disorder, you really want to address that and strengthen her bones that way by fixing what the fundamental problem is. So what you can do and what you're supposed to do is order certain biochemical tests of the blood and the urine, and these are going to detect whether there are any common abnormalities that typically can lead to the likelihood of osteoporosis. So it's very common to detect vitamin D deficiency. Some patients lose too much calcium in their urine, so that's calcium that should be staying in the bones and not going out in the urine. You can detect malabsorption by doing a blood test that screens for celiac disease. So the results of your blood test can give different clues. So for example, obviously if a patient has a low vitamin D result on their blood test, that would be indicative of vitamin D deficiency. If a patient has a high alkaline phosphatase, that might be suggestive of osteomalacia. Specifically, it could be vitamin D deficiency. If the patient has a high serum calcium, that could be consistent with hyperparathyroidism or even malignancy. If the patient has a high 24-hour urine calcium, it might mean they're losing too much calcium in their urine. Or a low 24-hour urine calcium might mean they have malabsorption because they're absorbing so little that they're trying to hold on to whatever calcium there is and not let it out in the urine. So I'm going to turn now to talk about medications that could be associated with osteoporosis. Anti-seizure medicines are important because they can interfere with vitamin D metabolism. I also want to highlight here GnRH agonists and aromatase inhibitors, which are commonly used as part of breast cancer treatment, because again, these medicines are just going to wipe out estrogen, and without having enough estrogen around, the osteoclasts will be unchecked in their activity to stimulate bone resorption. But far and away, the most important of these is glucocorticoids. And this is, first of all, because they're so ubiquitous and given for almost every condition under the sun, but also because they really can have such a devastating effect on bone. So glucocorticoids can harm the bone in a number of ways. First of all, at the level of the gut, they will decrease calcium absorption. So it's almost like they're having an anti-vitamin D effect, because we know normally vitamin D enhances calcium absorption at the intestine. At the same time, at the level of the kidney, glucocorticoids are going to increase the excretion of calcium. So it's kind of like a double whammy effect, because you're both absorbing less calcium at the intestine and excreting more calcium at the urine, so you'll be in net negative calcium balance. At the same time, glucocorticoids can have an effect to cause a central hypogonadism. So oftentimes premenopausal women who begin glucocorticoids become amenorrheic because of an inhibitory effect of glucocorticoids on gonadotropins. But the glucocorticoids can also directly affect the bone, and initially they have an effect to increase bone resorption or stimulate osteoclast activity. But the real big hit is the toxic effect that glucocorticoids have at the level of the osteoblast. So there's very, very low bone formation in patients who are on glucocorticoids, and that's really the main insult. So the important point for you to remember is that any patient who's on glucocorticoids or who's about to start glucocorticoids should be a person who has a bone density that gets checked. So this moves me into the next section, which is how do we diagnose osteoporosis? And our gold standard is to use dual energy X-ray absorptiometry or bone mineral density testing. And this is really our clinical mainstay. And it's able to measure the sites that we really worry about the most, namely the spine and the hip. It's also able to measure the wrist. And what's really great is that we have very large normative databases that we could use. So you can compare your patient to someone who's the same age, the same race, and the same gender, and have a very robust, validated comparison. It's also very accurate. So if you were to actually scoop out a piece of your patient's bone and measure in a lab what the bone mineral content is, it would match very well with the bone mineral density test that you're getting from this tool. More than that, it's very precise, which is not the same thing as being very accurate. The difference between being precise and accurate is that being precise means that you could repeat the test over and over and have a very high likelihood of getting the same exact measurement result. So it has that quality as well. It's also very safe. So it's only about 1/5 the amount of radiation of a chest X-ray. It's actually less of a radiation exposure than if you were to take a flight across the country. And then most important of all, which is the whole reason we do it in the first place, is that it correlates with fracture risk. So that's why we want this information, because we want it to be a surrogate to tell us who's going to have a fracture before it actually goes on and happens, and it's able to do that extremely well. So you can see here that as bone density decreases, as you go down here on the x-axis, the fracture risk is going to increase, and it's really a very tight relationship. And in fact, for every standard deviation decrease in the bone density, the fracture risk is going to double. And I would submit to you that this is as good or even better than the relationship between a rise in cholesterol and a rise in cardiovascular events. So really there is an excellent predictive value with the bone density measurement and the risk of someone going on to have a fracture. So this brings us to the question of who should have a bone density test. If you're seeing a patient in clinic, is this a patient who you should say to him or her, you really should go on to have a bone density test? So there's really no debate, and it's universally accepted, that every woman who's 65 years or older should have a bone density test. So this is really totally what should be standard of care, the same way we think about mammograms or colonoscopy. Any woman 65 or older should have a bone density test. And likewise, any man who's age 70 or older. These are really kind of accepted guidelines. In terms of anyone who's younger, if they have any of the risk factors that we talked about, so for example, if they had a fragility fracture, which means a fracture from a fall of standing height or less, if they're on glucocorticoids, if they have rheumatoid arthritis, if they had a parent who had a hip fracture, if they had premature ovarian failure, that's going to be a person who is at risk for having low bone density and someone you would consider doing a bone density in as well. So when you do a bone density, this is kind of what the output looks like. You get a picture of the site that's measured, and 3 numbers are printed out. You get the actual bone density, which is the raw score. You get something called a Z-score and something called a T-score. So what the Z-score is, which kind of makes sense intuitively, is how your patient compares to other people of the same gender, race, and age. So in other words, if I'm measuring an 80-year-old Caucasian woman, her Z-score is going to be how she compares to other 80-year-old Caucasian women. The T-score, on the other hand, is how she compares to someone who's at peak bone mass. So for the example of my 80-year-old Caucasian woman, her T-score would be how she compares to a 30-year-old Caucasian woman. So obviously people are going to tend to have worse T-scores than Z-scores because it's a more strict measurement to be compared to someone who's at peak bone mass rather than people who are their age. So the Z-score is somewhat useful because you're really going to be alarmed if your patient is 2 standard deviations worse than everyone else her age, and that would really make you think there must be another problem here that's going on. But in fact, it's really the T-score that we use for diagnostic purposes. So the way the T-score is defined, it's how many standard deviations your patient's bone density is as compared to that of the young adult reference population or someone at peak bone mass. And the T-score was chosen to be used for diagnosis because the World Health Organization found that a T-score in a postmenopausal Caucasian woman was predictive of how likely she was to have a fracture later in her life. So it was found that someone who had a T-score of -1 or higher was considered to have a normal bone density and be a very low risk of going on to have a fracture later in her life. Someone who had a T-score between -1 and -2.5 fell into the category of osteopenia, and someone with a T-score of -2.5 or worse falls into the category of osteoporosis. So it is important to remember that these cutoffs were devised based on data from postmenopausal Caucasian women. So they don't really technically apply to women who are premenopausal or to men or to people of other ethnicities, but nevertheless the convention has become to use these cutoffs for the breakdown of normal osteopenia and osteoporosis. So it's also important to make the point that someone could be considered to have osteoporosis if they've had a spine or a hip fracture, or if they've had a fragility fracture. So their T-score could even be normal on bone density, but if you have a patient, let's say a woman who went to open a stuck window and pulled really hard to open it and had a sharp pain in her back and went on to have a vertebral fracture, even if her T-score at her spine is technically normal, this is a person who's had a fragility fracture, who's had a spine fracture. This is someone you're going to categorize as osteoporosis, regardless of what her numbers are on the bone density. What we've recently also begun to do is when we have our patients get a bone density, we also take a sideways look at the spine, and this is called vertebral fracture assessment. And it's very useful because remember, I told you that 2/3 of spine fractures are silent. So patients won't have pain from that. Only 1/3 of the time will they know it. So this gives the doctor a chance to be able to look at the vertebrae and to see, do they look nice and straight and full? And you could see here in the circled area that there's been a concave anterior wedge fracture. So you could see that there's a collapse and that vertebra doesn't look nice and straight as it should. So this would be a way that you would pick up a vertebral fracture in your patient while she's having a DEXA, and this could very well change how you're going to treat her and how you're going to think of her, because now you know that she's a person who has osteoporosis. So in terms of who gets treated, it kind of makes sense that if someone has normal bone density, you're not going to treat them with a drug. You're just going to use things like calcium and vitamin D. You'll hear more about that in the next lecture, and lifestyle interventions. If someone has osteoporosis, remember, which we said is a T-score minus 2.5 or worse, or a hip or a spine or a fragility fracture, you're going to treat them with a drug. But what's really tricky is what to do with patients who fall into this middle zone with osteopenia. How do you know if you should be treating these people or not? So first, are these people even at risk? I can't tell you how many people come to see me in the clinic and say, Dr. Rubin, I'm here because I have osteopenia. So could I tell such a patient, like, just don't worry about it, I'll see you next year? Or should I tell this patient, you really might have a fracture, you need to be treated? Well, first of all, we do know that these patients do fracture. This was a very large epidemiologic study led by one of my colleagues, Dr. Cyrus, and what it shows is that people of osteoporosis by bone density have a 4 times increased risk of fracture, which makes sense, but people who have osteopenia do have a 1.8-fold increased risk of breaking a bone. So if you have osteopenia, you can't just sit back and not worry about it. You could fall into the category of being at risk of fracturing. And what's even more compelling is if you look at this data, and what this is showing that as the bone density gets worse and worse and worse here, the fracture rate increases. So that kind of makes sense, right? The worse your bone density is, the more likely you are to have a fracture. That's kind of intuitive. But what's really surprising is that the actual gross number of fractures is in fact highest in the women who have osteopenia, not osteoporosis. So most of the fractures in this country are happening in people who have osteopenia, not osteoporosis. And if you guys think about that, why that might be, it's just because the sheer number of people who have osteopenia is so much greater. So in fact, most fractures are occurring in these people. So we need to really think of a way about how to ferret out which of these women with osteopenia we need to worry about and which we don't need to worry about. So what's really important to understand is that not all T-scores are the same. So 2 women could have the exact same T-score on their bone density measurement, but you need to think about other risk factors that are going to make you think about them differently. And there are a bunch which you could think about, but I would argue that the 3 most important are, is the patient on glucocorticoids, what is the age of the patient, and has she had a prior fracture? So we already talked about glucocorticoids and how that's really such an important risk. And just to let you know, the risk with glucocorticoids can be present even in a dose as low as 5 milligrams a day for an amount even as little as 3 months of taking the treatment. But I'm going to tell you now about the other 2 important risk factors, which are age and prior fracture. So we know that age in and of itself is going to increase the risk of fracture, totally separate from what the bone density is. So if you see here on the red line, this 50-year-old woman, if she has a T-score of minus 2.5, her risk of breaking a hip over the next 10 years is maybe like 2 or 3%. But if you go up to the 80-year-old woman on the purple line, who also has a T-score of minus 2.5, her risk of breaking a hip over the next 10 years is about 4 times higher, about 12%. So these 2 women have the exact same T-score, but because one is 50 years old and one is 80-year-olds, the hip fracture risk is dramatically different, which really tells us that there's something about age that the bone density test is not fully capturing. So it's not enough just to think of the patient's T-score. You really have to think of what her age is, because that's going to dramatically increase her fracture risk. In a similar fashion, you have to know whether the patient has had a fracture before. So we have a saying in our field that a fracture begets a fracture begets a fracture in a very devastating cascade, because once a woman has had a fracture, or a man, their likelihood of having a fracture goes up dramatically. We know that if a woman has had a vertebral fracture, if you don't do anything, she has a 1 in 5 chance of going on to have another vertebral fracture in the following year. And if she's had multiple vertebral fractures, the risk goes up even more. No, in addition, the risk of having a hip fracture is twofold just from having that one vertebral fracture. So this is really to make the point, and this is probably the most important point that I want to make today, which is that if a patient has a fracture, it's critically important to think about evaluating and diagnosing that person for osteoporosis and then treating them if it's appropriate. So you don't want to have a patient coming in and having a fracture and getting a cast in the ER and then going home just to go on to have that next fracture, because we know once you've had one, you are very likely to go on to have another. And unfortunately, we know from data here, this is with women who had Colles fractures of their wrists, that the vast majority of them who came to the hospital got treated by the orthopedic surgeon for their fracture, and there was no warning or any instructions in terms of being diagnosed or evaluated for any other cause of osteoporosis or being treated. And I'm not saying this to speak badly about orthopedic surgeons. It's really to tell you who are going to grow up to become different types of doctors, OBGYNs, internists, rheumatologists, endocrinologists, surgeons, that if a patient has a fracture, an alarm needs to go off in your mind so that there's a closed loop between the people who are fixing the fracture and the people who can prevent the fracture. And in fact, only about 50% of women even have a DEXA, elderly women, and less than 20% of people who come into the hospital with a fracture are ever diagnosed or treated for osteoporosis. So I'm moving back now to this question of how to tease out which women with osteopenia you need to be worried about. And I'm going to tell you about a relatively new tool that we have. It's called FRAX. It's something that's online. You can Google it and get onto the website yourself. And it's an incredibly valuable tool for us that was developed by the WHO a few years ago. And it's based on worldwide epidemiologic databases that allow you to incorporate other clinical risk factors together with bone density to see how likely your patient is to have a hip fracture or any type of osteoporotic fracture. So as I'll show you, you plug in data about your patient, including the bone density at the hip, and it'll spit out for you numbers where it gives you percentages of, based on all the risk factors put together, how likely your patient is to go on to have a fracture in the coming years. So when it's clear that the patient has osteoporosis, it's a no-brainer, and you're going to treat them with a drug. When the patient has normal bone density, similarly, you're going to counsel lifestyle interventions. But here, this really comes into play when the patient is in this gray zone of osteopenia, and you're not sure if you could tell her not to worry or that she does need treatment. So you're going to enter these pieces of information about your patient, the age, how much they weigh, how tall they are, have they had a previous fracture? So remember, we said that's a critically important risk factor. Did their parent ever break a hip? Are they smoking? Are they using glucocorticoids? Do they have rheumatoid arthritis? Other secondary causes of osteoporosis? Do they drink? And then what their bone density score is at the hip. And it calculates for you these numbers, and in this country it's been decided that if there's more than a 20% chance of your patient having any major osteoporotic fracture over the next 10 years, so that includes a fracture at the spine, hip, wrist, or humerus, that's somebody you're going to want to treat, even though she has osteopenia, or if the patient comes out to be having more than a 3% chance of having a hip fracture over the next 10 years. So I'm just going to briefly show you what it looks like. This is what it looks like if you go onto the website. So first you have to pick your population because it has databases from all over the world. So we would pick North America and we would pick United States. And then you go on to enter data. So here in this example, your patient's age is 63. You've entered her weight and height. She does not have any of the risk factors that we talked about, like a previous fracture, a parent fracturing a hip. You would enter her T-score, which as you can see here is minus 2.3. So this is falling into the osteopenia category, exactly when you'd want to use this tool here. And you can see that the calculation you get is that she has an 11% chance of having a major osteoporotic fracture in the next 10 years and a 2% chance of having a hip fracture. So is this someone you would want to treat or no? Right, she doesn't meet that cutoff of 20% for major osteoporotic or 3% for hip fracture. But look, now in this slide, we've altered it and changed it so that her parent did have a hip fracture. So you could see when you rerun the calculation, now she actually does meet the criteria for treatment because her risk of having a major osteoporotic fracture has now gone up to 21% over the next 10 years. So just changing that weighted risk factor is going to change how you're going to treat this patient because now she has a different likelihood of a fracture. And this one's a little bit blurry, but all the other risk factors are back to normal, except that now she did have a history of having a previous fracture. And here again, you could see now you would treat her because her hip fracture risk is greater than 3% over the next 10 years. And then lastly, here, 2 changes have been made. Her age went up from 63 to 68. And her bone density at the hip went down from -2.3 to -2.4. So changing these 2 things, again, would change the numbers you get, and you would treat her here based on the 3% for the hip fracture. So you can't just totally blindly rely on this, even though it's very useful and valuable. You have to remember that certain things might be underestimated. So just for example, the glucocorticoids is like yes, no. It's not saying is the patient on 100 milligrams of prednisone a day versus 5 milligrams of prednisone a day. So it kind of misses that subtlety, so it could be underestimating the fracture risk. Some risk factors are just not included at all. We think that diabetes is a risk factor, but that's not included, nor is certain medications that we know that could harm the bones. You'll notice that you only enter the bone density of the hip and not of the spine. So what if you have a patient who has a really great hip bone density but a very bad spine bone density? So then your calculation might be underestimating her risk as well. So there is a little bit of an algorithm you can use to account for that. It doesn't take into account someone's risk for falling, which can hugely increase their risk. And the databases were set up only to include people who never got osteoporosis drugs. So it's not ideal if you're using this on a patient who's already been on an osteoporosis drug, but recent studies do show that you can actually use it in that situation also. And what you can tell your patients is that the risk for them having any osteoporotic fracture is actually even higher than the calculation you're getting for major osteoporotic fractures. So a lot of times this can be very helpful in giving patients a sense of the seriousness of their condition. So I'm just going to review here how we think of this. So we said any woman over 65, any man over 70 must get a bone density. If the T-score is -2.5 or less at the spine or at the hip, or if they've had a hip fracture or spine fracture, is this someone you're going to treat? Yes, okay. And it's really important because, as you'll hear in the next lecture, we have very effective treatments, so you really want to be able to pick these people out. If someone falls into the osteopenia gray zone, what you're going to do is the fracs and see what their 10-year fracture risk is, and if they meet these cutoffs for hip fracture, osteoporotic fracture, then that's someone that you're going to treat as well. So basically, the point of this first part of the talk is really to give you that overview of osteoporosis and really set up the next lecture where you're going to hear all about the different types of treatment options that are available. So you should understand who it's appropriate to get a bone density on, who it's appropriate to treat, and who it's appropriate to do further evaluation, like with the FRAX tool. So I'm going to switch gears now to the last part of the talk and talk about other metabolic bone diseases. None of these are as prevalent as osteoporosis, but they're also important diseases that you should also know about. So I'm going to cover the 4 diseases that are listed here. The first one is osteomalacia. So as we kind of mentioned before, bone is really made up of 2 materials. One is the collagen, which you could see here in this sample of bone where the mineral was digested away on the right, and the other is the mineral. So the collagen is the organic matrix that's laid down by the osteoblasts, and the mineral is the hydroxyapatite crystals that encrust the collagen and give the bone a lot of its strength. So really, bone is supposed to have both components in it, and it's about 98% mineralized. Only 2% is unmineralized. And you need to have the right amount, because if the bone is excessively mineralized, it's going to become very brittle. One physiologic example of that is the stapes bone in the inner ear, which is so mineralized and brittle that it's able to vibrate and pick up sounds and transmit them to the auditory nerve. But osteomalacia is kind of the opposite problem, which is when you don't have enough mineral in the bone and you have this soft, unmineralized osteoid, which kind of feels really like the collagen in your ear. And it's going to happen if the bone is not able to obtain enough mineral to lay down on the scaffolding that's been put down by the collagen. So the classic example is vitamin D deficiency. You need vitamin D to absorb calcium and phosphate from your intestines. So if you're not getting enough vitamin D, maybe because you're not exposed to sun enough, or you don't have enough nutritional sources, or maybe you have liver or kidney disease because those are necessary to convert vitamin D to the active form. You thus won't absorb enough calcium and phosphate from your intestine, so the bone won't become adequately mineralized, and you'll develop these so-called soft bone where there's too much of the unmineralized osteoid. And the typical symptoms that can develop are diffuse dull bone pain. This typically occurs in the pelvis and in the lower extremities. People can have tenderness to palpation of their muscles and can walk with a waddling gait, and they can develop fractures with little trauma. And if you see it on an x-ray, it actually looks like the radiologist did a bad job taking the film, because it looks like the film is blurry because there's too little mineral that's present. But this is actually really suggestive of there being too little mineral that's been acquired and of the state of osteomalacia. And if you look on a bone biopsy, this is a normal green spicule of bone here, but this red strip is not normal because that's suggesting that there's an excess of osteoid, or the organic component of the bone, that has not become mineralized as it was supposed to, which could predispose the bone to being weak and to fracturing with minimal trauma. So when this happens in children, it's a little bit different, and it's called rickets. And the reason it's different is because they are still growing their skeleton. So because their epiphyseal growth plates are still growing, when there's poor mineralization there, it's going to lead to widening of the ends of the long bones. So children with osteomalacia will develop a specific abnormality anatomically, which is bowed and fragile knees. And you could see here the picture taken from children at the time of the industrial age where there wasn't enough exposure to vitamin D, and they'll develop these painful abnormalities in the knees and also be predisposed to fracturing. I'm going to turn now to discussing chronic kidney disease, mineral and bone disorder. So this is a constellation of what happens in patients who have kidney disease, and it involves three components. One is mineral abnormalities, so derangements in calcium, phosphate, vitamin D, PTH. The other is bone abnormalities, so derangements in bone turnover and bone mineralization. And lastly, vascular abnormalities, because these patients are also prone to developing calcium deposition in their blood vessels. So when patients first develop the beginnings of CKD, as the nephrons begin to drop out, the phosphate is going to start to rise because the kidney is not able to excrete the phosphate as it normally should. Along with that, FGF23, or fibroblast growth factor 23, is going to begin to be secreted by osteocytes, cells in the bone. And this is kind of a functional response because one of the effects of FGF23 is to lower phosphate and get rid of it in the urine. So it's going to help to counteract the increased phosphate that's resulted from the beginnings of the development of renal insufficiency. But another effect of FGF23 is to lower calcitriol. And this is going to have the effect of lowering serum calcium, because we know that calcitriol, or activated vitamin D, is necessary for absorption of calcium from the intestine. Moreover, because the kidney is not functioning well, it itself is going to not be able to make calcitriol, because we know the enzyme, the renal 1-alpha hydroxylase, that stimulates the conversion of 25 vitamin Z to 125 dihydroxyvitamin D, or calcitriol, is going to be dysfunctional. So there's two reasons that calcitriol is getting low. One, because FGF23 is suppressing it, and the other because the enzyme in the kidney that normally stimulates its production is becoming decreased. So taken together, there are all these reasons that calcium is going to be lowered. Having a high phosphate in and of itself lowers calcium because phosphate complexing with calcium lowers the amount of available circulating calcium. Having decreased calcitriol is also going to lower calcium because you need calcitriol or activated vitamin D to be able to absorb calcium from the intestine. So to compensate for these things, parathyroid hormone rises. So in a way, it makes sense, and it's an appropriate physiologic response because parathyroid hormone, first of all, is able to dump phosphate into the urine, so it's going to help with the rising phosphate. Parathyroid hormone is also able to turn on bone resorption and thus get calcium out of the bones and available in the circulation. So parathyroid hormone is going to be able to counteract the low levels of calcium. And finally, parathyroid hormone is able to stimulate the renal 1-alpha hydroxylase in order to facilitate the formation of the calcitriol or the activated 125 vitamin D. So parathyroid hormone is going to work those three ways to kind of get the phosphate down and get the calcium up and get the calcitriol back up, which really does help in the short run with normalizing the mineral abnormalities, but it's at the expense of having this prolonged hyperparathyroidism, or what's known as secondary hyperparathyroidism, so the bones are really going to pay the price for it. And there's 4 types of bone disease that can occur in this setting, and they all need to be diagnosed by a bone biopsy. You really can't make any of these diagnoses without actually looking at a piece of bone under a microscope. One is osteitis fibrosis cystica, which basically means too much parathyroid hormone. So everything is super revved up. The osteoclasts are all juiced up and resorbing bone. There's a very high state of bone turnover, and this is a result of the high PTH level. The other problem that can develop is osteomalacia, and this is really less of a problem nowadays because it was more when aluminum-based phosphate binders were used in patients with kidney disease because the aluminum could interfere with the mineralization of the bone. Another one is adynamic bone disease, and this is probably the one that's most commonly seen in dialysis patients. And this is where everything in the bone is turned off, and it's really because someone has tried to suppress PTH too much. So let's say you've given the patient a lot of calcium-based phosphate binders, so that's going to shut down PTH. You might have given the patient a high amount of calcitriol, so all that is going to turn PTH down so low that everything gets suppressed and you're in a state of very low bone turnover. Mixed bone disease is kind of a combination of any of these pictures. So I just want to show you what adynamic bone disease looks like under the microscope, and you could see that there's very low bone volume because no new bone is growing, everything is turned off. There's very low osteoid, which means the amount of new bone that's being laid down by osteoblasts, so there's almost none of that. There's no osteoclasts that are seen. If you try to do labeling, which is to see how much dynamic activity is there, you'll see nothing. So basically, it's kind of like an overzealous treatment of the high PTH. So what do you think the way to treat this would be? It's really to allow the PTH to rise. So you would maybe dial down on the calcium-based phosphate binders or on the calcitriol dose that's being given. I'm going to now just talk briefly about these last 2 diseases. So the first one is Paget's disease, also known as osteitis deformans, and this is when there are focal areas of accelerated bone remodeling leading to overgrowth of bone. So there's just certain random spots throughout the skeleton that are having this disorganized, accelerated bone turnover. A lot of the time, the patient doesn't have symptoms, but sometimes they can have pain and deformities, which you could see on the x-ray, and I'll show you in 1 second. And the way you diagnose it is by an elevated alkaline phosphatase. So the reason they have an elevated alkaline phosphatase is because it's reflecting this disorganized, accelerated state of bone formation. And you treat with bisphosphonates, which is really to reduce the pain if they're having pain and to reduce the rate of bone remodeling. And the way you know your treatment is successful is by monitoring the alkaline phosphatase. So this is a skull of a woman who has severe Paget's disease, and you could see the thickening of the skull plate here, as well as these classic cotton wool spots, which are reflective of these lytic and sclerotic areas, which show the disorganized bone formation and bone resorption. You can also see in this tibia here that there's a very thickened cortex here, and you could see these clearer areas and thickened areas, and that's because there's been tunneling of these pegetic osteoclast cells that again lead to these lytic lesions and sclerotic lesions. Lastly, I'm just going to mention osteogenesis imperfecta, which is an inherited connective tissue disorder, also known as brittle bone disease, which results when there are mutations in the genes that code for proteins that combine to form type 1 collagen. And there's a very wide range of how severely it can present. I've seen patients who really have almost no manifestations, but it can even be so severe as to present in utero with multiple fractures and death in the early newborn period. But really the risk to these patients is that they can develop fractures with minimal trauma because essentially they have abnormal collagen. So this is an abnormality in the matrix component of the bone in contrast to there being an abnormality in the mineral component of the bone. And even though bisphosphonates are not FDA approved for use in this disease, this is the most common treatment that's used with reduction in the fractures that these patients have. And one of the pathognomonic signs in these patients is that they have blue sclera, and it can be very striking if you ever see it in a patient. So in conclusion, I've presented to you an overview of the epidemiology and diagnosis of osteoporosis and an overview of 4 important metabolic bone diseases. So I would exhort you as you go forth in your careers to not forget about the bone and remember us boneheads. And now I'm going to leave you for the next lecture, which will go over the treatment of osteoporosis. Thank you. Hi.
Kids go back to normal?
Not necessarily. A lot of times you need surgery, so you could correct the metabolic bone disease and heal the bone sort of mineralized, but the anatomic defects can always be reversed.
Is it like easier to treat when you're younger because they have more time?
Yes, yes, and their bones are less formed. Yes, sure.
Did you want me to plug it in? I think it's down there.
I plugged it in.
Oh, it's here.
Yeah. Thank you. Okay, why don't we convene? Let's get started. So I was told this is the last of the formal lectures for your whole year. There are 2 reviews, is that right? I think you have 2 review sessions this afternoon, but so I hope this won't be the worst, but hopefully it'll be one of the most enjoyable. We're going to talk about the future in terms of treatment of osteoporosis. And this will logically follow the lectures that you've had, Dr. Dempster, Dr. Shane, Dr. Rubin, and me. So we are going to appreciate, hopefully, the need for effective and safe therapies to prevent osteoporotic fractures, to review nutritional elements that are useful, and to summarize our current knowledge of the safety and efficacy of pharmacological therapy of osteoporosis. And here's the outline of non-pharmacological approaches for all of us to maintain our skeletal health, and then specifically, what can we do non-pharmacologically for osteoporosis, and then to talk about the drugs that we have available that sort themselves into 2 classes, anti-resorptives and osteoanabolic therapy. So this is really this is a case of a patient on the left at the age of 50, and this is a patient on the right, same person, 25 years later. And unfortunately, this picture and sequence is reproduced over and over again. This tracks the course of osteoporosis in a woman who looked pretty normal, although if you look very carefully, maybe you're not sure about this roundedness that she had already developed at the age of 50. Dr. Rubin has pointed out some of the epidemiological data. This is a big-ticket item when we talk about healthcare economics. 10 million women in the United States over the age of 50, another 20 to 24 million women with low bone density, and the lifetime risk of a fracture is high. Almost 40 to 50% of women over the age of 50 will have either a vertebral hip or forearm fracture before the age of 80. The annual incidence in women is about 2 million fractures per year. This is a woman who obviously has osteoporosis. She is sitting on a park bench. She doesn't move around very much anymore. It's difficult. And the more she sits, the more she's going to be in negative calcium balance. This is one of the diseases that is not associated with obesity. Now, those thoracic compression fractures push the gastric system forward and actually reduces the volume of the stomach, so she doesn't eat very much. For every thoracic vertebral fracture, she has a reduction in her vital capacity, and in fact can have clinically reduced pulmonary function. You can imagine her trying to get comfortable in bed. And looking at her a little bit more carefully, you can see that she's just had her hair done. You can see maybe she's wearing lipstick. And you can see she's wearing heels. She probably shouldn't be wearing heels. What does all this say? This says that maybe this woman is trying to look as she used to look, as well as she possibly can. But this disease robs women of their self-esteem. They don't live as long. And as you can see, that image is not what she thinks of herself. And don't forget the men. We have described this disease in men as the forgotten gender. And I think Dr. Rubin mentioned comments about the incidence. About 25% of osteoporosis occurs in men. And that turns into about 10 to 12 million if you include the osteopenics and the osteoporotics compared to the women. Again, in the way of recapitulation, this is a disease of compromised bone strength, predisposing to an increased risk of fracture. And bone strength is seen microstructurally. This is normal bone. This is osteoporotic bone. This is not only what Fuller Albright said in 1942, too little bone, but this is bone that is disordered and biomechanically not competent. Again, reviewing the major risk factors on the left and the important other risk factors on the right. And to a certain extent, these risk factors are independent of each other, and the FRAC score appreciates a weightedness of these major clinical risk factors, putting it together in an algorithm that allows us to include these other risk factors along with bone density to come up with a risk assessment tool that is useful clinically. Now, from the point of view of therapeutics, what we want to do is to prevent this process of microstructural decay from normal to not so normal to, frankly, osteoporotic. The major drugs we have available for the treatment of osteoporosis help to prevent this process, stabilize bone wherever it is in this process by increasing bone density or stabilizing it, maintaining trabecular microstructure, and increasing mineralization density of the skeletal matrix. Now, our goal might be even more ambitious, to take this osteoporotic piece of bone and make it less so and even possibly to normal. So we are going to discuss how to treat and how to prevent this disease. Now, for all of us, now all of you are very young, but I would include you also, whether or not we have a skeletal disorder, these are good things to do. It is good to exercise, preferably weight-bearing exercise. Probably the best weight-bearing exercise is walking. That's all you have to do, but you need to walk. Or other, of course, weight-bearing exercises. For those of you who don't like to walk, or you don't like to jog, don't like to lift weights, maybe you like to swim. And it has been said that swimming is not a weight-bearing exercise. Well, it isn't, but you've got to do something to keep yourself from sinking, and that, if you will, anti-hydraulic exercise is also positive. Nobody should smoke, period. The incidence of smoking in this country has been reduced, just yesterday I heard, to about 11 to 14%, which is really quite amazing. Smoking is bad for every organ system. There's no point in smoking. And excessive alcohol intake. And by that we mean more than 3 units per day. Units is a British term. We say 3 drinks per day. By the way, modest alcohol intake with regard to skeletal health is not a negative, it's actually probably beneficial. And then adequate calcium and vitamin D. Somebody asked me yesterday about calcium supplements. We are recommending a total intake of calcium from all sources of about 1,000 to 1,200 milligrams per day. We prefer us to get our calcium intake through natural sources, and the most important natural source of calcium is dairy. We use calcium supplementation only to make up the difference between the amount of calcium in the foods you're taking, including calcium supplemented foods, and what you really need. And if you are a vegan, let's say, and are not getting any dairy, you are going to have to take in calcium supplements. More than 500 or 600 milligrams at a time is not advised because your absorption will suffer of calcium if you take more. And preferably, calcium supplements should be taken with a protein-based meal because you'll get an advantage of calcium absorption by taking a protein-based meal. The 2 major sources of calcium supplementation are calcium carbonate and calcium citrate. Calcium carbonate is preferred because 40% of calcium carbonate is elemental calcium, so you don't have to take as many pills as you would have to with regard to calcium citrate. Calcium carbonate does require a source of acid, either gastric acid or the acid in food, such as protein, for absorption. As I mentioned before, it's enhanced with food. Some people complain of calcium carbonate causing gas, bloating, and constipation. Calcium citrate may have an advantage by not requiring acid for absorption. Again, it's enhanced with food, and it is thought to cause fewer of those GI issues. If you go to the drugstore, you will see a myriad of different calcium supplements. There are lots of generics, and there are a number of branded. My wife has said, and it's worth quoting her, she says, Americans have the most expensive urine. With regard to calcium, you don't have to go for the high-priced calcium. The generic formulations are just as effective. So the story with calcium is in dairy. Skim milk or low-fat dairy products have actually more elemental calcium than full-fat dairy products. So you drink your low or non-fat milk, eat your low or non-fat yogurt, eat your cheese, and use calcium supplements only to supplement. Now, if you are supplementing, it's not going to kill you. All the literature, somebody told me that there is the Internet, of course. The Internet is the greatest source of misinformation. It says, if you just log on willy-nilly, that calcium will cause coronary artery disease. Everything has to be done in moderation. Calcium supplements in moderation does not cause coronary artery disease, does not cause cerebral vascular disease, does not cause hypertension. And in fact, there are a number of prospective studies, most recently a month ago, that has documented what I just said. When calcium is used in excess, of course, you do have to worry. But we are not recommending calcium in excess. Vitamin D is the key to calcium absorption, and all of you know the activation pathway. We use 25-hydroxyvitamin D as our index of calcium sufficiency or insufficiency. The magic number, I believe, that is the number we should aim for, is 30 nanograms per ml. Epidemiologically, and this is actually a real paper, looked at levels of 25-hydroxyvitamin D less than 30 nanograms per ml, and you can see that the parathyroid hormone level goes up as a function of those lower 25-hydroxy levels. And since D and PTH are intimately related to each other, you don't want this secondary hyperparathyroidism to ensue in people who are vitamin D deficient. So I think 30 nanograms per ml is preferable, although the Institute of Medicine, for their own reasons, has recommended 20 nanograms per ml. But if you ask me, and I think the literature would argue, and many of the major societies would agree with me, that 30 nanograms per ml is the desirable level and not 20. Vitamin D deficiency is common in the United States. If you look at a United States population, almost 60% of a normal free-living population in this country has levels of 25-hydroxyvitamin D less than 30 nanograms per ml. And it's not just in the United States, but throughout the world. I was just in Hangzhou, China, where the incidence of vitamin D deficiency is upwards of 70%. And this study from Paul Lips makes the point that 64% in this latitude range, which is where most of the people in the world live, had levels of 25D less than 30 nanograms per ml. So the question is, what's happened to the sun? The sun should be our source of vitamin D. We are designed to make vitamin D when skin is exposed to sunlight, particularly during the middle, spring, summer, and early fall months when the wavelength of sun required to activate pre-vitamin D in the skin is hitting the earth. But the problem is that it is seasonal to a certain extent. There are concerns about sun exposure with regard to skin cancer, particularly melanoma. There are cultural issues, particularly in some parts of the Middle East, where women are completely covered, and, by the way, men are also. I just mentioned I was in China. I was there for 5 days, and not once did I see the sun, but it wasn't raining. The pollution in some countries is so much that the sun never gets through. Our dermatological colleagues say avoid sun exposure, use sunblock for the reasons I just mentioned. So the sun has been essentially eclipsed as a major source of vitamin D throughout the world. We are recommending intakes of 600 to 800 units per day with an upper limits of normal of about 4,000. Vitamin D2 is ergocalciferol, the plant form of vitamin D. Cholecalciferol, vitamin D3, is the animal form. We are animals. We make vitamin D3, not vitamin D2. And some people have thought it intuitive, therefore, that vitamin D3 is better. I don't know if it's better. It's very hard to prove it's better. And if you go again to the drugstore and look at all the different vitamin D preps, it really doesn't matter, I think, whether you take or your patients take vitamin D2 or vitamin D3. Again, as I mentioned before, if you go with the Institute of Medicine, you go for greater than 20. If you go with most of the rest of us, you would want your patients to have levels greater than 30. Okay, that's for all of us. Now, what about your patients who have osteoporosis? What I just said goes, and you want to take measures to take issue with the propensity for falling. I don't care how bad the osteoporosis is or how low the bone density may be. If a patient doesn't fall, is she going to break her hip? Yes? No? The answer is no. 95% of hip fractures occur after the fall, not before the fall. So anything you can do to prevent falls will go a long way to preventing the fracture. Eyesight, if you could improve that with corrective lenses. Hearing, home safety, ambulatory devices, risky behavior. By that I mean people doing things they shouldn't do, like standing on a chair with 2 telephone books to change a light bulb. You know that? That's kind of not a good idea. And also things like hip pads. So if you were to do a home visit, those of you going into family medicine, when you do your residency, you will make a home visit. You'll go and see where your patients live, and you will notice a lot of things noted here that are literally inducing falls to happen. And the extent to which you can deal with these issues, and they are correctable, you will help to prevent falls. And here are some assisted devices that a lot of patients don't like to use, but it certainly will give them additional support and help to prevent falls. There's some interest in hip pads. This is a garment that was popularized about 10 years ago. You can see the hip pads on either side. And the idea is that when an older person falls, and older people tend to fall to one side or the other, not necessarily forward, they would fall on this padded surface. And although this seems like a good idea, it didn't become very popular. And you can imagine why. Even if you're 85 years old, you don't want to increase the size of your hips. And somebody told me that the only way hip pads are going to gain popularity is for them to work like airbags. You know, so when you fall, they kind of explode, and there you're protected. Actually, I'm going to have a call tomorrow. There's a new hip pad that's being designed, and I'm interested in seeing how this new hip pad might work. Okay, let's move on to pharmacological approaches. The decision to treat, it's not such an easy decision to make. But if a patient has a fragility fracture, she has, or he has, osteoporosis, unless you're dealing with a pathological situation. And that is an imperative for treatment. If your patient has a T-score that meets that osteoporotic threshold of minus 2.5 or less, that also is an indication to treat. And the FRAX tool that Dr. Rubin talked to you about, if your patient meets one of these two thresholds of greater than 20% over 10 years for any fragility fracture, or greater than 3% for a hip fracture, even if they don't have osteoporosis by T-score, even if they don't have not had a fragility fracture, just by FRAX alone, you can justifiably recommend treatment. And the treatments we have available let's start with the anti-resorptives. The mechanistic rationale is shown here. These are drugs that reduce bone turnover. They reduce bone resorption, a phase of bone turnover, to a greater extent than they reduce bone formation. So they alter the balance from, if you will, bone loss to bone gain, permitting bone formation to proceed, granted at a lower rate because the bone formation and bone formation processes are linked. If you reduce bone resorption, you usually reduce bone formation, but not to the same extent. And by reducing the number of bone remodeling units over time, you're reducing the number of those stress risers, which are points of vulnerability. Here are our agents that we have available. They are FDA approved, and we'll go down this list, touching on some of them lightly and others in somewhat more detail. Estrogen has been much aligned, and in some respects for good reason, but in terms of the skeleton, estrogen is a fabulous drug. The Women's Health Initiative documented this, whether this arm was with estrogen and progestogen or with conjugated estrogen only, there was a reduction in clinical fractures significantly in compared to the group that didn't get treatment. And even with regard to hip fracture, estrogen was shown to be effective in reducing hip fractures. The problem with estrogen, and we won't belabor the point, the negatives of estrogen replacement therapy in many cases outweigh the putative benefits such as fracture reduction and the reduction in colon cancer. So estrogen is actually not a primary treatment for osteoporosis. We do not use it in the treatment mode. It does have an indication for prevention, but here again, it isn't used as a primary treatment. The selective estrogen receptor modulator field has given us a single drug for osteoporosis. The idea of a SERM is that it gives you the agonist properties of an estrogen on the skeleton and perhaps also on the cardiovascular system, while behaving as an antagonist at the breast and the uterus, two other target tissues for estrogen. So it's a hybrid type molecule, taking the best of estrogen and actually turning into an anti-estrogen when it comes to the breast and the uterus. And this is the drug that we have available in this country for the treatment of osteoporosis. It's called raloxifene, and you can see some resemblance to estrogen. And this drug actually tends to be able to bind in an antagonistic way to the estrogen receptor in this portion of the molecule, and in a positive way with regard to the effects on bone and perhaps also lipids. So raloxifene is used. It's actually a big drug in this country. It is well absorbed from the gastrointestinal tract, can be taken any time of the day, one pill a day at 60 milligrams, with or without food, and it doesn't seem to have any adverse GI effects. In those who have never had a pre-existing fracture, at 2 different doses, but this is the approved dose, it reduces vertebral fractures very significantly. And individuals who have already had an osteoporotic fracture, you can see the control rate is much higher. If you've had one fracture, you're going to have another fracture, and so on. It also reduces the incidence of the next fracture very significantly. There are disadvantages to raloxifene. It's an anti-estrogen in the CNS, so it will cause hot flashes. Leg cramps can be a problem. It can be associated with deep vein thrombosis, like estrogen, and can increase the risk of pulmonary embolism, like estrogen. And it can increase the risk of stroke, like estrogen, and the strokes under the influence of raloxifene can be associated with increased mortality. On the other hand, it improves bone density, reduces vertebral fractures, doesn't have negative effects on the breast or the uterus, and in fact, in those who are, let's say, predisposed to estrogen receptor positive breast cancer, it actually can reduce that risk. And there's no increased cardiovascular risk. Let me move on to calcitonin. It is still on the list of approved treatments for osteoporosis. It's used these days as a nasal administration. The indication is for postmenopausal osteoporosis. Calcitonin has a very small effect on bone density, no effect on women within 5 years of the menopause. And in that famous study that was called PROOF, it was shown at this dose, 200 units, that there was a reduction in vertebral fractures, and only vertebral fractures, in women with pre-existing fractures. There was no effect shown in non-vertebral fractures or hip fractures. So the data are not all that compelling. Most of us do not think that calcitonin is a particularly useful agent and do not consider it as a first-line or even a second-line treatment. Furthermore, more recently, there has been an issue raised, namely an increased incidence of certain kinds of cancers in subjects treated with nasal calcitonin. This is all epidemiological data, remains to be confirmed, but it has cast a shadow on the attractiveness of calcitonin for those who thought calcitonin was an attractive treatment. The big class of treatments for osteoporosis is the bisphosphonates. And here are the 4 bisphosphonates that are currently used and approved, not only in the United States, but throughout the world. Alendronate was approved in 1995. Risedronate was approved in 2000. Abandronate came along a few years later. And zoledronic acid is the most recent, approved in 2007. And you will notice that these drugs have all a very similar molecular structure. They're bisphosphonates. They're pyrophosphate analogs. Pyrophosphate has a POP structure, and it's a normal product of metabolism. The bisphosphonates have a carbon atom here, rendering them insusceptible to the pyrophosphatases in the circulation. They are not metabolized. They have tremendous affinity for mineralized tissue. The more recent bisphosphonates, such as risedronate and zoledronic acid, are nitrogen-substituted bisphosphonates, and the nitrogen in several different configurations gives even a greater affinity of these drugs for bone. They are attracted to bone, and they have a very, very long half-life in bone. They are orally available. They are very poorly absorbed, an absorption percentage of somewhere between 0.6 and 1.5%. They have to be taken in a very special way in the morning, in the fasting state for most of the bisphosphonates, with plain water. Patients do not go back to bed. They are not to drink or eat anything for the next 30 minutes. For abandronate, the waiting time is 60 minutes. There is one formulation of risedronate that can be taken with food or after eating. It's a slow-release, delayed-release formulation for those who can't go through this procedure. The half-lives are fast or slow. They are rapidly taken up, and what isn't taken up in the bone is cleared by the kidney. These are magic bullet drugs. They have no interest in any other organ system in the body except bone. And what isn't picked up by bone is rapidly cleared, unchanged by the kidney. In bone, on the other hand, once there, they have a residence that can be measured in years. There is a GI intolerance associated with the bisphosphonates. It's an esophagitis, it's a gastritis. For those who are predisposed to gastritis or esophagitis, it can be exacerbated. It's a pill contact type irritant, and the pill, as it is being dissolved, can be physically irritating to the gastric and esophageal mucosa. It happens about 10 or 20% of subjects, but not by any means everyone. Now, the bisphosphonates work in a very special way. They adhere to bone, as I mentioned, and then they find their way into the active bone remodeling system, and they find their way literally into the osteoclast. and they are eaten by this macrophage cell. And as they are eaten by the osteoclast, they have very profound effects on osteoclast function and osteoclast survival. As anti-osteoclast agents, in some respects, they will kill the osteoclast, preventing further bone resorption, but allowing bone formation to come into this bone remodeling unit and fill what would ordinarily be a negative bone remodeling unit. So they work as anti-osteoclast agents, and when they get into the osteoclast, they inhibit a very important enzyme, farnesyl pyrophosphate synthase, which is actually on the pathway to cholesterol synthesis. But there's another pathway, as cholesterol pathway, that leads to the production of very small molecules. They are small G proteins that are anchoring proteins on the surface of the osteoclast. And by disrupting these anchoring proteins, these bisphosphonates then disrupt the cellular membrane and render these osteoclasts, as I said, dysfunctional. Alendronate, the first of these bisphosphonates, has a very impressive effect. This is when we use the drug daily, increasing bone density, as you can see, in the drug arm versus the placebo arm, and with very significant reductions in clinical vertebral fractures, X-ray-based vertebral fractures, and even more profound, a 90% reduction in multiple X-ray-based vertebral fractures. Risedronate, a kissing cousin, if you will, also has been shown to very effectively reduce vertebral fractures over a 5-year period. Ebandronate, similarly, has been shown to be very effective in reducing vertebral fractures. Finally, zoledronic acid given intravenously, this is an intravenously acting agent, has been shown to reduce vertebral fractures over the 3-year clinical trial, as you can see in orange. Non-vertebral fractures, we are, of course, wanting to reduce fractures across the board, not just vertebral fractures. And for alendronate, risedronate, and zoledronic acid, it has been shown very clearly that they all reduce non-vertebral fractures. With abandronate as the only exception, there is only post hoc data to suggest that abandronate may have effects to reduce non-vertebral fractures. In terms of dosing, alendronate and risedronate are given as a weekly dosing, once a week. And as I mentioned before, risedronate has a formulation that allows it to be taken with food. Monthly oral dosing, abandronate and risedronate have formulations that allow patients to take either of these drugs only once a month. And as I mentioned, zoledronic acid is a once-a-year drug for osteoporosis. Ebandronate has also an intravenous formulation, but that has to be given every 3 months. Now, what about adverse events? I mentioned the upper GI effects only with the oral agents. The intravenous bisphosphonates do not affect GI function. There may be an acute phase reaction with the IV agents primarily, and this is kind of a flu-like syndrome. Patients will say they've developed a fever, they get myalgias, they get a headache. It tends to last for just a couple of days. Occasionally, this acute phase reaction can go on for about a week or so. A very rare syndrome, a musculoskeletal pain syndrome, has been seen. I think I've seen it once in 20 years. Not common. More important, and again, if you go on the internet, you'll find this immediately. The so-called atypical fractures that occur after long-term continuous use of the bisphosphonates. These atypical fractures are called chalk stick fractures. Literally, the mid-shaft of the femur breaks. The patient is walking off the curb and the leg snaps. There may be a prodrome of leg pain. There is some radiological features that may be also prodromes of the atypical fracture. It occurs. Also, osteonecrosis of the jaw occurs. I noted that atypical fractures are rare or very rare, and osteonecrosis of the jaw is very, very rare. And this is an area of the jaw that is exposed after tooth extraction, let's say, or after very extensive dental hygiene work. And the exposed bone doesn't heal, and it looks necrotic. It is an association between the bisphosphonates, although it has never been shown that bisphosphonates actually cause osteonecrosis of the jaw. How rare are these syndromes? Osteonecrosis of the jaw occurs with the same frequency of your risk of getting hit by lightning. It's true. Now, do you worry about getting hit by lightning? If you're in New Mexico, maybe, because people get hit by lightning in New Mexico. But I'm making the point because patients will tell me, "Doctor, I don't want to take this drug because my jaw is going to fall off." They have accessed misinformation on the internet. I am not belittling these very serious adverse events, but put it into context. You're preventing fractures, and every once in a while something happens. Nothing you do in life is safe. Correct. You cross the street on Broadway, you're taking a risk. Put it into context. So, in patients who have done well and whose fracture risk is lower after 3 to 5 years, we do agree that it might be reasonable to stop therapy, the so-called drug holiday, and reassess later. In subjects whose risk remains high, bone density continues to be low, or they've had a fracture in the interim, the risks of stopping, in my opinion, may be greater than the risks of continuing. So every patient is different, and you have to reevaluate them whether they are eligible for the so-called drug holiday or whether they aren't. But across the board, we don't say you're on drugs forever, at least in our field, nor do we say you're all going to have a drug holiday after 3 to 5 years. Let me move on to another class. This is a very exciting drug. On June 1st, about 5 years ago, the FDA approved denosumab, dosed subcutaneously 60 milligrams every 6 months for the treatment of postmenopausal women at high risk for fracture. It also has an indication for men who have osteoporosis to increase their bone density. Now, let me go back and introduce to you rank ligand. You may have heard about rank ligand already. This is a product of the osteoblast and the osteocyte. Rank ligand is a powerful activator of the osteoclast. It is also a powerful activator of the lineage pathway to the mature osteoclast. Rank ligand is one of the most powerful bone cytokines in the universe, and if we hadn't evolved to control this cytokine, all of us would be jellyfish. That's how powerful it is. So what we have in our circulation, in our system, is a natural inhibitor of rank ligand called osteoprotogerin, or OPG, shown here in green. So what OPG does is to circulate, as does rank, and it will identify rank and, like a Pac-Man, just catch it and prevent its access to its cognate receptor, rank, on the osteoclast. So in this way, rank ligand and OPG are in some kind of an equilibrium, hopefully in a steady state, so that we don't have too much activated rank ligand around. How powerful is rank ligand? In an OPG knockout, no OPG around, you see there's no bone. Here's the control. And if you actually have an OPG transgenic animal, you actually grow a lot of bone. So this is a system that is very, very powerful. It did not take long for the biochemists and the bone biologists to develop a human IgG antibody against rank ligand, and this is denosumab. And when it is given, it circulates in the blood as an antibody, does not go to bone, it has no interest in bone, doesn't have an interest in any organ system, it just circulates as an antibody, and it, like OPG, finds rank ligand, binds it, and prevents it from activating the osteoclast. So denosumab is an anti-resorber, but working completely differently from the bisphosphonates. The major phase 3 trial that was published about 6 years ago, I won't go into the details here. It was a very well-controlled, placebo-controlled clinical trial. And here are the data showing that new vertebral fractures, non-vertebral fractures, and hip fractures all were reduced very significantly in comparison to placebo over the 3 years of the clinical trial. As far as side effects of denosumab are concerned, not much to talk about. Atypical fractures have been seen. Osteonecrosis of the jaw has been seen, but again, very, very rare. A cellulitis was described in the initial clinical trial, a bacterial infection of the leg that was easily treated by antibiotics. But as we have become much more familiar with denosumab, and as the clinical trials are now extended out to 10 years, that imbalance of cellulitis has not held up. So I have reviewed for you all of these agents. All of these agents are anti-resorbers, again, with different mechanisms. Now, let me go back and recount this picture of preventing bone loss, stabilizing microstructure, and increasing mineralization density. That's what these drugs do. But, here we go. But as I said before, I don't know, this gizmo is not working. What we want to do is to reconstruct the skeleton. And some of you may still dare to dream that it's possible to take a broken down piece of bone and not only convert it to a better bone, but to normal bone. And for this discussion, we are going to talk about osteoanabolic therapy. Osteoanabolic therapy has only one member of the class. It's called teriparatide. Teriparatide is human parathyroid hormone 1 to 34. Let me just remind you that we have talked about parathyroid hormone being bad for bones, right? You saw this picture yesterday. Why are we now talking about a fragment of parathyroid hormone that is good for bone? And the history of this is really fascinating. It really goes back to the first extractions of parathyroid hormone in the 1930s, but no one had paid attention to this for about 50 years. It turns out that if you give parathyroid hormone intermittently, 1 hour a day to a rat versus continuous exposure, you unmask a osteoanabolic potential by stimulating the osteoblast, while the continuous administration of PTH leads to a negative catabolic effect. So the idea is continuous PTH is not good for bone, but daily low-dose PTH is actually good for bone. The clinical trials, and we're going to talk only about teriparatide because PTH 184 is not available as a treatment for osteoporosis. So we're talking about the foreshortened fragment of parathyroid hormone that has all of the classical biological activities of the full-length molecule. The clinical trial, which was conducted many, many years ago, again, typically well-designed, placebo-controlled, multinational, 2 doses of PTH 1 to 34 were used, 20 and 40 micrograms. The approved dose is 20 micrograms. And the data showed that with regard to new vertebral fractures and non-vertebral fractures, there were significant reductions in the group that got the teriparatide versus the group that got placebo. There also were reductions in fractures independent of whether patients had mild or severe previous fractures, whether they had single or multiple fractures. There was also evidence that it reduces back pain. So, what do the bones look like after patients have been treated with teriparatide? And this work comes from our own group. Dr. Dempster, whom you heard from last week, did these biopsies, and you can look at the bone biopsy before and after teriparatide. And it's pretty obvious what you're seeing. You're seeing trabecular bone much better connected, greater trabecular thickness, better connectivity. As well, you're seeing the cortical envelope of this bone biopsy much better. And if you look at that, those pictures I showed you before, and these pictures I just showed you now, it's very interesting what is happening. Teriparatide is transforming this bone into more normal bone. In fact, it doesn't look too much different from that normal biopsy. So the idea is that these osteoanabolic agents, and there are a number that are being developed now, may have the capacity, literally, to reconstruct the skeleton. So here is the summary table. The yellow and the pluses indicate where there is good evidence for efficacy. And you can see the 3-bisphosphonates get pluses across the board. Estrogen gets pluses across the board. Denosumab gets pluses across the board. Abandronate makes only vertebral. Raloxifene only makes vertebral. Calcitonin, if you believe the data, gets a plus here. Teriparatide got pluses for vertebral, non-vert. The study wasn't big enough or carried out long enough to know whether teriparatide affects hip fracture. So let's go back to this picture and just sort of think for a moment. If we could have identified this woman at the age of 50, either by bone density or by recognizing that thoracic vertebral fracture, or by having done a FRAX, and if we had been so smart and could have treated this woman, could we have had this outcome? Now, clearly, she would have been 25 years older. She wouldn't look identically, right? But she would look more like this than she turned out to be. So I think, and this isn't just fanciful thinking, I think now we're on the verge of really talking about osteoporosis not only as a preventable disease, not only as a treatable disease, but also as a curable disease. And I think over the next decade, as this field continues to be vibrant with new ideas and new therapeutic approaches, we may well reach that endpoint. Thank you very much for your attention. Well, you're all done. Congratulations.
Are there like notable side effects or contraindications for teriparatide?
There is an animal publication about this, and not to see a lead, 15 years to plus. And someone who has had in children who are growing, and people who have hypercalcemia, and those too. And the other contraindication is someone who has unexplained increase in alpha bones to single alpha. So there are contraindications.
I should recommend it.
Well, maybe so. To fix the will, because most people don't have any alpha. That's a thought. I don't use it for a third time. It was a proven shoot. Really one of the best answers is with by our lectures. Some of the other people know it. So you get material that should be treated as well. You know, for the right section of dosing is, well, it's an injection every day. We will tell you about I had one patient who wasn't able to manage. It comes as a light reservoir cartridge. It doesn't just it's right in the field. Shows you things every day. It's so cute. The needle is so strong you can't even see it. So it really isn't a problem.
Another question we had, have there been any interest in trying to develop like a fluorostomy or something like that?
There's a major phase 3 trial that is halfway finished to develop an anti-sclerostin. The drug is called bromociclib. I have to say that a few times. Bromociclib. There's also another drug that is a different agent in development, but it's an anti-sclerostin, and it's called bromociclib. So but you're absolutely right. I'm very good thinking, because that theoretically should be a sure and and the early read is it is with lososumab. In 1 year, in phase 2 trial, bone density increased by 17.7%. That's almost 2 teaspoons in 1 year. Unbelievable.
That's great.
Yeah, so that's why I was sort of hinting at that.
Thanks for coming.
That was great.
Very interesting.
Yeah.
Thank you very much.
Great.